Hi, this is Manos Brilakis, and this is video 24.2 for the Manual of Percutaneous Coronary Interventions. This video discusses how to do PCI in patients with cardiogenic shock. Cardiogenic shock is usually defined as a low cardiac output state that results in life-threatening end organ hypoperfusion and hypoxia, and traditionally in the cath lab it is diagnosed in the presence of persistent hypotension, usually systolic blood pressure less than 90, despite fluid administration, that is due to cardiac dysfunction with hypoperfusion and cardiac index less than 2.2 and wedge more than 15. However, hypotension alone is not necessary or sufficient for a patient having cardiogenic shock. For example, a patient may be hypotensive because of technical reasons, not really having true hypotension, or the patient may be hypotensive because of hypovolemia, for example, in cases of retroperitoneal hematoma, or because of peripheral vasodilation in the cath lab, for example, because of anaphylactic shock in response to contrast. Cardiogenic shock has to do with hypotension due to cardiac failure, although some patients may be in shock and have hypoperfusion while maintaining a systolic blood pressure in the low normal range. Using a Swan Ganz catheter can be extremely useful for determining the cause of the shock, but also for guiding subsequent management. SCAI has recently developed the 5 stages of cardiogenic shock, A, B, C, D, and E, starting at risk, then the beginning shock, the classic shock, the deteriorating shock, and then the extremist shock. How do the 14 steps of PCI apply to patients who have cardiogenic shock? We'll start with planning. Planning is critical for being ready to treat patients who have cardiogenic shock. And the importance of protocols cannot be overemphasized. Protocols can help with early identification of patients with shock and prompt management, which can have tremendous impact on the subsequent course of the patient. They emphasize the importance of right heart catheterization with a Swan Ganz catheter, prompt revascularization of the CULPRIT-only lesion, use of mechanical circulatory support, as well as access to advanced heart failure therapies. This is one such protocol from Innova Medical Center, in which patients with suspected cardiogenic shock are evaluated by a shock team that is a multidisciplinary team consisting of interventional cardiology, cardiac surgery, advanced heart failure, and critical care. And then depending on the cause of cardiogenic shock, whether it is acute MI or congestive heart failure, the patient is then transferred to the cath lab. Hemodynamic assessment is performed to guide subsequent management. This is another similar algorithm, the National Cardiogenic Shock Initiative, that also emphasizes the importance of obtaining hemodynamic support, as well as performing assessment of the hemodynamics with the Swan Ganz catheter. Monitoring is critical in patients with cardiogenic shock, as they can often have rapid deterioration. The hemodynamics are, of course, particularly important, both systemic pressure but also the right heart hemodynamics. Assessment of perfusion, for example, assessing the patient's mental state, urine output production, and also measuring lactate. These are some of the commonly used hemodynamic measurements. For assessing the performance of the left side, one measurement is the cardiac power output, which is calculated by multiplying the mean arterial pressure from the cardiac output and dividing by 451. The goal is to be more than 0.6. And then for assessing the right side, the PAPI, or pulmonary artery pulsatility index, is calculated as the difference between the diastolic and the systolic pulmonary arterial pressure divided by the right atrial pressure. And the goal here is to have more than 0.9, otherwise less than 0.9 suggests right ventricular failure. These are some examples of cardiac power output. A patient with a mean pressure of 60 and an output of 5 has a CPO of 0.66. However, the same patient, if the output is 4, then actually the CPO is 0.53, suggesting left ventricular failure. This is a normal pulmonary artery pulsatility index. Usually the pulmonary artery is a pressure of systolic of about 25, diastolic of 10. That is divided by the right atrial pressure of 5 normally. That gives a PAPI of 3. And this is an example in a patient who has relatively okay hemodynamics. But this is an example in another patient who has fairly narrow pulse pressure in the pulmonary artery, 30/20, so that means 10, and also has high right atrial pressure of 15. In this patient, the PAPI is 0.67. This patient has right ventricular failure, therefore may need right ventricular hemodynamic support. Moving on to pharmacology, and this is particularly important in cardiogenic shock patients. Pharmacologic interventions are typically the early ones used before mechanical circulatory support is used. The vasopressor/inotrope of choice is norepinephrine, and there are several videos discussing administration of those patients separately. Moving on to access, both femoral and radial access are okay. However, given the frequent need for hemodynamic support in those patients, usually femoral access is preferred, although it does carry increased risk of bleeding complications. Engagement and angiography are done as per standard practice. Often the operator is trying to minimize the amount of contrast, however not at the cost of obtaining a complete picture of the coronary arteries. And then in terms of determining the target lesions, there is an important difference in patients in cardiogenic shock versus those without. Specifically, patients who have cardiogenic shock should undergo PCI only of the culprit lesion. Based on the CULPRIT shock trial, doing multivessel PCI of the non-culprit lesions was actually associated with higher mortality and risk of renal failure. Preparation of the lesion, wiring of the lesion, stenting, and closure are done as per standard practice. When it comes to coronary physiology, that has very limited role in patients with cardiogenic shock because the hemodynamics are altered and the left ventricular pressures are often quite high, making the calculations of the FFR and the resting hemodynamic indices not being accurate. Imaging, however, can often be used to optimize the result of PCI in those patients and also reduce the administration of contrast. And finally, use of hemodynamic support can be of critical importance in patients with cardiogenic shock. This is discussed in video 14.1, but the choice of device depends on several parameters. First of all, on the presence of hypoxemia or not. If there's hypoxemia, then typically VA ECMO is used. Second, on the presence of right ventricular failure. If there is biventricular failure, typically VA ECMO is used. If it's isolated right ventricular failure, for example, in patients with right ventricular dysfunction, then a right ventricular support device, most commonly Protect Duo at our institution, is used. Patients who have cardiogenic shock due to pure left ventricular failure then can receive a hemodynamic support device depending on the severity of the shock. At early stages of shock, a balloon pump may suffice in some selected patients. For patients with severe shock, an Impella or the tandem heart can be used. And patients who do have refractory shock often receive VA ECMO. However, even if the patient receives VA ECMO, increasingly there is offloading of the left ventricle by using a balloon pump or an Impella device as well. So in summary, patients with cardiogenic shock are patients who have high risk. They do have high mortality, around 50% in most series, and in whom there is a need for rapid assessment, including hemodynamic assessment using right heart catheterization, as well as prompt coronary revascularization if needed, treating only the culprit lesions, and then use of hemodynamic support to optimize the hemodynamics and reduce the needs for vasopressor and inotropes, which have been associated with higher mortality in this setting. Thank you very much.